Hi, I'm Amanda St. Ivany, and I realized I didn't actually put my email address up there, but you can find me in the UVA. Look up, I'm a PhD student here in nursing, and I actually came to nursing as a second degree. So I have a sociology degree that gathered a lot of dust for years, and I had a good friend who became a quadriplegic, and I went through the rehab process with him, and that's kind of what really got me into nursing. And so I started my pre-nursing career as a rehab tech at Craig Hospital in Denver, which is a traumatic brain injury and spinal cord injury rehab hospital. So I worked there for 2 years. I did recreation for people with disabilities before I did that, while I was taking prereqs to go back to nursing school. And I keep forgetting, but I was actually one of the first people trained in the Wounded Warrior program when it was started in 2008. And so that's a pretty cool organization, and it's been fun to see it grow. So I went to nursing school in Baltimore at Johns Hopkins, and I did a second degree program there and really got interested in violence against women. I had worked in some women's shelters before that. So I'm here today to talk to you about my dissertation topic, which is traumatic brain injury and intimate partner violence. And I'm going to go over just a little bit about head injury, and I'm going to focus more on mild traumatic brain injury and concussion than I am on sort of full-blown traumatic brain injury, partially because talking about and diagnosing a traumatic brain injury is not my area of expertise, and I'm much more comfortable talking about mild brain injury, concussions, sort of the changing state of the science. Last year I did a literature review for my course on traumatic brain injury and intimate partner violence, and I'm excited to say it's being published as we speak in the Journal of Family and Community Health, so I'll highlight some of the findings from that. And I presented that at a traumatic brain injury provider conference in Colorado, hosted by the same hospital where I used to work. So that was really fun, and that's really where my sort of knowledge shifted on the current state of head injury and concussion. So we can go ahead and go to the first slide. I have no financial interest to disclose. And then my objectives are to discuss brain function and to give an overview of TBI. And I did put a slide up here with a link to a website that gives you different lobes of the brain and what they do, but I'm not going to get too much into that because you've all had that before, and that's pretty easy stuff to look up if you need it. I'm going to talk about the changing of diagnosis and outcomes, and talk about really how to screen for a mild traumatic brain injury. Talk a little bit about the traumatic brain injury in intimate partner violence, talk about barriers to care and why people don't seek help when they're in abusive relationships, and then I'll close with a video at the end. So this is just the overview of neuroanatomy, and for the folks here, Kate brought the card so you can look at that, and if you're at home you can click on that, but we're not going to click on that here. That's more of just a reference for you if you need to refresh your memory of what your different lobes in the brain do. But just know that different parts of your brain control different things, and depending on where you get injured or where the injury occurs is how the injury will manifest. So I have to spin this way a little bit to see it, but this is actually the definition of a mild traumatic brain injury, and it's from the Brain Injury Association of America. And I picked it because it was the easiest, and it really just sort of makes sense. So if someone comes in and they say, I've had this accident, what you're going to do is you're going to ask them these questions. Did anybody see you, or do you feel like you were confused? Do you have problems with your memory? And one of my big rants is you're asking people if they have problems with their memory, that have problems with their memory. So it's kind of like, do you hit your head? I don't remember if I hit my head. And so I don't think that one actually works very well, although it's documented that it does, but I don't believe it. Observed signs of neurological dysfunction. So some of the stuff that Kate was talking about before, either motor things, anything with the eyes, anything with seizure-like activity, or sudden fainting or falling or stumbling, anything like that that just seems like it could be related to the brain. You know, if you have a little weird thing that happens and a lot of people just write it off, that could actually be, if you've hit your head recently, that could be related. And then observed or self-reported loss of consciousness. So did you pass out? Did you black out? Did you faint? Is there any chunk of time that you don't remember? And we know clinically that we'll give the Glasgow-Coma scale where you check for pupils and motor function and arousal state and level of consciousness, but that's not really, people don't do that to themselves at home, and especially in my interest area, women who are abused, they're not saying, are my pupils equal? Or someone's not there with a flashlight checking them, or even the police. I mean, if there are people who respond, they're not checking for these clinical signs, which is why I'm not pulling in a lot of the clinical stuff here. But basically, if you're doing a neuroassessment, it's the same for a traumatic brain injury as it is for a stroke. And honestly, a lot of the problems that come from traumatic brain injuries are brain bleeds. They're just caused from something else. So when Kate was talking about the hemorrhagic strokes being 13% of the strokes, and one of the little things that cause it is trauma, that's usually a traumatic brain injury. And the tip that I learned when I was at the conference last year is if you're doing noxious stimulation to try to get either a motor response or a localized response on someone and you suspect that they don't have control of their limbs, do it on their earlobe. Not like the sternal rub if you're really trying to wake someone up, but if you're touching someone's nail beds and if they have a spinal cord injury or if they can't feel that, they're not going to respond, but really they might be able to if you touched somewhere else. So if you touch someone's earlobe, you can kind of pinch it. You'll see people turn their head. So that's a pretty good way if there's possible spinal cord damage. If they can still move their head, you can give them credit for localizing to pain because they're able to respond in that way. That was one of my favorite tips. So this graphic is from the CDC, and it just has the leading causes of traumatic brain injury. So falls, a lot of that we see in the elderly population. Struck by or against, I think that's where sports falls, because we know that there are a lot of sports-related concussions, sports-related traumatic brain injuries. 12% unknown and 9% other. I don't know what that really means. 10% assault and 17% traffic accidents. And this relates to what I will talk about later, but for the most part, these are public events, right? So if you smash your car, the police come or the fire department comes, the ambulance comes, you go to the hospital. If you are an elderly person in an assisted living facility and you fall, you get taken to the hospital. If you're in a fight and someone sees it, if you're incarcerated, some type of assault like that, people see it. So if you can click to the next slide, please. We see that, I didn't put the numbers up here because it doesn't really matter, but 75% male and 25% female, basically. So if you're thinking about these numbers, it makes sense that you see more males than females because we're talking about public events. We're talking about things where people are responding. If children are at home and they fall and nobody sees it, they're not being included in this. But from my arguing perspective, there are a lot of women who are being abused that aren't being captured by this. And that's what my literature reviewed showed too, and I'll talk more about that a little bit farther along, but it's abuse is underreported and mild head injury are underreported. And it's not just people saying, no, you can't go to the hospital. It's, oh, I hit my head, but it wasn't that hard, so I'm just gonna keep going. And then if it's a cabinet and you hit your head the same spot on the cabinet in your kitchen 4 times in a year, then you're actually giving yourself sort of mild head injuries along the way. So if we can keep going. So this is a very fancy graphic, and it just goes to show you the red is falls, and it goes by age category. So little kids fall a lot, and then older people fall a lot, so that's the red. And then in the middle, you know, people don't really fall that much. And then the green is struck by and against, which is why I think they were including sports, because that's 5 to 14 and 15 to 24. Those are pretty big gaps where people are playing sports. And then all other causes is sort of the purple, and the unknown is the gold. So the top 2, those are things that are being reported, but people still don't really know how to account for what their causes were. So I don't know this graph well enough from the CDC to say this is what happened, but these are people who reported to the emergency room. So what I'm saying is if we can improve our screening tools and improve the way that we ask the questions, then maybe we can start to make a dent in the all other causes unknown. So really for little kids, that's only like less than 10%. But as you get older, it gets to be more, especially in this middle range. So from maybe 5 to 14 through 45, that's a pretty big chunk of all other causes. And we know that violence against women mostly occurs in your 20s. That's when women are most likely to be abused. Sort of late teens through mid-20s is when most of the abuse happens. So we can go to the next one. And the thing that I learned at the conference, and that I've been seeing more in the literature, is that brain injury, it's not an acute medical disorder. So it's not like I get in a car accident, I hit my head, I have a brain injury, I come in, I have a Glasgow coma score, I go to rehab, I get better, and I go home. End of story. That whole perspective is changing, and even the way they do research is starting to change. So the keynote speaker was really arguing to stop doing randomized control trials on head injury, because every person is so different, and every injury is so different, and each person's recovery is so different. And there's a lot of work being done on genetics right now, and brain recovery, and linking history of head injury to Alzheimer's, and there is one specific gene, the ANK1, that's sort of related to head injury recovery and Alzheimer's. But so far, there's no gene that makes you more prone to getting a head injury. It's all about how your body recovers. So as what we know is changing, the whole mindset is shifting from this is an event that happens to this is a whole process of things that happen. And if it was an event and there's not an intervention, the event is most likely to happen again. If you're driving and you don't wear your seatbelt and you get in a car accident, then you get a brain injury. If you're driving and you still don't wear your seatbelt, it's a pattern repeated. The same thing with the sports and the concussions and girls soccer. High school girls soccer is one of the highest rates of concussion, which blew my mind. But if there's not a change made in the rules of the game or how long the girls are allowed to sit out before they return, then those things are going to keep happening. So as the knowledge is shifting and we understand it as a disease process, but we still screen and we still diagnose it as if it were an event. So if you get a diagnosis of a traumatic brain injury, you have your MRI scans and your CTs and your Glasgow coma scales and all of the other things that go along with that. And there's nothing really that says your CT was negative, your MRI was negative, maybe you had a concussion, and then you send people home. So that's kind of why I was really excited when Kate said, will you come talk? Because I was like, yes, these are the people that can help. So what I pulled up was just an example. I'm not here advocating to add more documentation to anybody's day. But this is the acute concussion evaluation form, and it's the ED version. And the reference that I put in at the bottom, I put the reference and then I put the website. They actually conducted a study with it, and it improved outcomes in children who came in with concussions by using the screening scale. So I just did a screenshot of the top of it, but it asked different questions. So amnesia before the event, amnesia after the event. Were there early signs of concussion? Did they appear a little dazed or stunned? Are they confused? Do they sort of take a while to answer questions slowly? Do they repeat the questions? Are they forgetful? So I just wanted to give you an example of a different type of screening tool that people are using to really help try to capture this new kind of concussion. And I really want to point to the early signs, sort of down here, appears dazed or stunned, answers questions slowly. Because in my work with women who are abused, that's how women answer questions, right? So I came upon my dissertation interest because working with women who are abused, they act like people with head injuries. And whether it's a head injury or it's PTSD or it's whatever. So I was sort of saying, and there were other people that worked there that said this too, these women, they're not being difficult. They really don't know, or it's hard for them to think, or they don't quite remember. And so you see it a lot in court cases. If they're called to testify, then they don't remember what happened, or they try to think, but they just can't do it. And so those are very similar characteristics. So we can go to the next slide. So this is some recent reports from the Centers for Disease Control and Prevention in 2013. So they quoted the Traumatic Brain Injury Act of 2008, which really is just talking about reducing the burden at the population level. So not changing practice in a clinical setting, but really getting out in the community and understanding what's happening out there. Why aren't people reporting head injury? What can we do about it? Because we want to improve those outcomes. I saw, just from an assignment I did this week, it's reported that 2% of the population lives with disability from head injury, but when a specific group did surveys of people seeking, like, not just shelter services, but mental health facilities, vocational rehab, 58% of people screened positive for some type of head injury with disabilities related to that. So that's a huge discrepancy between 2% and 58%. So somewhere out there is the truth, but there are people out there who live with head injuries that aren't getting any type of intervention. The 58%, there were maybe some veterans included, but not, it was a population-based sample, not specifically veterans. But you bring up a good point. A lot of the research on veterans with repeated concussion and head injury, I'm hoping in maybe 5 or 10 years can start to translate to people in other violent situations or repeated trauma type of events. So, like I said, the reason that we want to do this is to target prevention resources at populations who are at greatest risk for traumatic brain injury. And one of the things that I'm specifically hoping to do with my dissertation is to look at the trends by TBI incidence, by injury mechanism, and population subgroups. So I'm looking at women who are living in violent relationships. So we can go to the next one. So both traumatic brain injury, head injury, and violence against women are underreported for many reasons. There's stigma that goes along with both, to saying that you're in an abusive relationship. There's stigma with saying, I'm not quite sure I remember, or a lot of people are afraid they will lose their jobs. A lot of people who do seek help do end up losing their jobs if they're unable to go to work for a certain period of time, or if they're prescribed some type of brain rest or break from activity and they're not able to take that time off work. Most importantly, people who are survivors of violence will not tell you until they're ready. And there are many, many reasons for that. One of them being because they know what they need to do to keep themselves safe. So if a woman is there and her husband is abusive, even if he's not in the room but he's behind the curtain and he can hear, she's not going to tell you because she knows that that might put herself in danger. And so it's really important to keep asking the question. I think it's important to keep asking the question for head injury, and I haven't seen that documented in the literature yet, but every time just asking people generic questions. Do you have problems with memory? If you had this headache, do you remember hitting your head? Did anything happen when you were a kid? Like, oh yeah, I was in a car accident when I was 12. Is that kind of linked? And I think if we start those conversations in the emergency department and then carry them through their hospital encounter, they can maybe start getting help for these problems. And if it's someone with a repeated headache, maybe they have a history of violence and they're afraid to say, my husband's beating me or my ex-boyfriend beat me when I was in high school, and now I have these lingering headaches. So it's in the way that you phrase the question, but it's also sort of how you ask the question, and if you keep asking it. You don't have to keep badgering them and say, tell me, tell me, tell me, but especially if you see people more than once or you see people with different symptoms each time, just really trying to understand what's going on and expanding your concept to think maybe they do have some type of head injury or concussion. Oh wait, go back one more just for a second. Oh, that's okay. So another important thing to remember about women who are living in abusive relationships is the abusers have the control. So I read some qualitative interviews from women in a study that I'm using for my dissertation, and I was really curious as to if they had received a head injury, why they didn't seek medical care afterwards, because the criteria that I used said, have you ever passed out from being hit in the head by your partner? And if they answered yes, I found their interview and I read it to try to find out what had been happening. And shockingly enough, the reason that they didn't seek medical care is because they were being forced to have sex. Those two extreme forms of control go together. So the abuser would use like some type of head injury as a last resort. So if the woman wasn't doing what he wanted, which usually include having sex with him, he would basically, caveman style, as crass as it sounds, hit her in the head and force her to have sex with him. Therefore, she is unable to seek help for the head injury, or she would get hit in the head and pass out and wake up and not remember. So it's important to think about the fact that women don't always have the control. They can't always come and seek help. So they might come for something totally unrelated. They might come for a hangnail, or they might bring their kid in, and if you have suspicions about the kid, or if the mom seems a little bit like she's very protective, think about reasons why that could be. And really they haven't found great interventions for any type of head injury, or especially mild head injury or concussion. Brain rest is a thing that they talked about at the conference with specifically teenagers, and how long they need to stay away from school, and can they watch movies, and can they have their phones and sit in a little dark room. But for most adults, that's not really practical, especially if you're someone with a family and have a job. Okay, now we're ready. So this was some of the results from my literature review, and 38 million women have experienced intimate partner violence in the US, and from my review of literature, it seems like 60 to 92% of women who are in abusive relationships have gotten some type of head or facial injury, which means that roughly 23 million women in the United States have some type of head injury from intimate partner violence. And it's not really being looked at or studied or talked about. If it is being looked at, it's trying to tease apart PTSD or head injury. So it's like, well, do these brain scans show post-traumatic stress, or do they show head injury? And my point is, it doesn't matter. If there's an intervention that works for one, it could work for both. Or if they're getting help for something, maybe they can get help for both. Did you have a question? No? Okay. So going back to the graph from before, 73% men and 26% women. So now that we've talked about it a little more, it does make a little more sense that we're not capturing all of the full spectrum of head injuries because we're not looking for them. It's almost like we have a little bit of neglect. So we're just looking at this area of the spectrum and we're not looking all the way out. So you can go ahead. So this is just sort of my how you can help. I didn't put links in from the Heads Up Concussion from the CDC, but there's a lot of great resources there. They actually have guidelines for medical providers. They have guidelines for nurses. They have patient discharge information about what is a concussion, what you should do about a concussion. And there is more evidence that shows one hit or one bump is bad, and the more you get, the worse off you are. That's more emerging research that's coming with that disease process. And even if women are not ready to disclose, what they say when they're asked in research situations is they like it when nurses ask them. They like it when someone takes time, even if they say no, even if they're not ready. They know that someone cares about them, and they know that someone is willing to take time out of their busy day or their busy life to say, is everything okay at home? Are you feeling okay? Is there anyone that makes you feel safe? You can switch it around. You can say, is there anyone that helps keep you safe? So it doesn't necessarily have to be, I don't know what the screening questions are here, or I think everybody has their own style, but if you just try to think about expanding it and think about if you were in a situation with something that was embarrassing and shameful or was possibly deadly, and you knew that if he found out that you were telling, he might kill you, try to think about nicer ways to say it. And really, even if it's the last thing that you want to ask or it feels uncomfortable, it really does make a difference to people when you ask. And I just said again, be patient when asking, because a lot of women do show similar signs of head injury or some type of neurological deficit, whether it's concussion or PTSD or just extreme stress. So we can go to the next one, which I think is the movie. So I played this video at the end of my class the other day, and we'll talk about it after it's over. It is a little intense. It's just women talking. But just be prepared. Where's the best place?
So it should be the first video. Let's do full screen. Nope.